Good afternoon and welcome to the Bipartisan Policy Center's event on improving Medicaid buy-in for workers with disabilities. I am Catherine Hayes, BPC's Health Policy Director. Today, we are releasing a report with recommendations to improve Medicaid buy-in for workers with disabilities. We've been working on this issue for more than a year, and to get to these recommendations, we've relied heavily on advocates, current and former state and federal officials, experts in this area. As part of our panel discussion in a few minutes, we will provide background on Medicaid buy-in and discuss the challenges and opportunities faced by states and individuals in implementing Medicaid buy-in. The focus of our recommendations are twofold. First, to heighten awareness of Medicaid buy-in by helping workers to help and recognize the importance of helping workers with disabilities remain independent, and to simplify and streamline Medicaid buy-in to make it easier for states and beneficiaries to understand those opportunities. Our recommendations include both short-term and long-term recommendations. In the short term, we suggest raising awareness by asking the President to issue an executive order and to rename the Medicaid buy-in program to be more descriptive. In our recommendations, we suggest Medicaid for workers with disabilities. We also urge CMS to issue regulations for the full range of options available. These programs are more than 20 years old, and guidance consists of two technical state Medicaid director letters that were issued more than 20 years ago. No wonder states are having trouble in programs. In our long-term recommendations, we urge Congress to streamline and simplify what we call Medicaid for workers with disabilities, to make it easier for states to implement and more understandable for beneficiaries. We also urge Congress to provide resources to states by reauthorizing the Medicaid implementation grants that were made available when the program was first implemented. I urge viewers to go to BPC's website for the entire report and its recommendations. Before we turn to our panel, I would like to recognize Kathy Hempstead, Senior Policy Advisor for the Robert Wood Johnson Foundation. RWJF has provided support for this project. Kathy?
Hello, good afternoon, everyone, and I'm really looking forward to our session today about the Medicaid buy-in for workers with disabilities. This is an option that we're going to learn has helped hundreds of thousands of people over the past decade. It's boosted income, helped people stay in the labor force, and it's cost-effective for states. But as Catherine alluded to, this is a program that's administratively complex and has been neglected by policymakers and subsequently been underutilized. So today we're going to hear more about these recommendations to make this program work better and help more people. And I would like to second the recommendation to look at the report, which has some fantastic background on this program, how it relates to other programs for people with disabilities, and it also provides more detail on the recommendations we're going to be talking about today. I see this issue about workers with disabilities and Medicaid as a specific example of a more general issue of how important it is that coverage supports work rather than the other way around, as some have thought at times, and that expanding coverage makes it easier for people to work generally. And there's some really good evidence from the ACA Medicaid expansions that makes that point as well. But this is a unique case of, I think, a more important general point. And I just wanted to close by saying that I can really relate to this issue personally as well. One of my sons has a disability and he has a job that he enjoys and can do very well, but he requires some special supports so that he can get to work and succeed there. And those supports are provided by the Medicaid program. So I'm keenly aware, as is my entire family, of how important that program is to allow people with disabilities to work and reach their potential. So thanks very much. Looking forward to the day.
Thank you, Kathy, and thank you for sharing your personal experience with us. I would also like to thank two members of BPC's health team who worked on this project, Brian Agara and Eleni Salyers. As I turn to our panel, I'd like to introduce Henry Claypool, who is Policy Director for the Community Living Policy Center at the University of California, San Francisco, and former Principal Deputy Administrator of the Administration for Community Living at the Department of Health and Human Services. Henry is also an invaluable consultant to the Bipartisan Policy Center. Next, Michael Gamel McCormick is Disability Policy Director for the United States Senate Special Committee on Aging, specifically for its chairman, Senator Bob Casey, a Democrat from Pennsylvania. Michael was also Associate Executive Director for Research and Policy at the Association of University Centers on Disabilities. Seth Gold is a health advisor for Senator Rob Portman, a Republican from Ohio. Before joining Senator Portman's staff, Seth served as a health legislative assistant to Congressman Michael Burgess, a Republican from Texas. And finally, I'd like to welcome Beth Waldman, a senior consultant with Baylet Health and former Massachusetts Medicaid director, where among her many accomplishments, she implemented a Medicaid buy-in through federal waivers even before Congress provided that authorization. You can go to our website to see their full bios. Throughout our discussion, you may submit questions in the live chat on YouTube or Facebook comments or through Twitter by using hashtag BPC. So I'd like to turn to our panel. And I'd like to cover three issue areas, starting with Henry and Beth. What I'd like to cover are the history and the need for the Medicaid buy-in program challenges for states and consumers. And because we have two Hill staffers, I'm very excited to talk about congressional perspectives and the opportunities for agency action. So starting with the history, Henry, I'd like to start with you. And Beth, please feel free to jump in, and Seth and Michael as well, if you have something to add here. Henry, can you provide a brief overview of the two Medicaid eligibility groups and what those programs were intended to do?
Sure, thanks, Catherine. I think the first and notable Medicaid buy-in that occurred in statute was with the Balanced Budget Act of 1997. And it allowed states to have individuals earn up to 250% of poverty. I'd describe this as a very kind of bare bones eligibility group, giving the state the option to create this eligibility group. It didn't define it too much beyond that, but it gave a hard cap at earnings and at the age of, it didn't actually touch on the age of the individual participating. So there are some, I won't say ambiguities, but the lack of definition in the statute does give states some opportunities, and we'll talk about that later. Second, along came the Ticket to Work and Work Incentives Improvement Act in 1999, which I had the pleasure of actually working on while I was at CMS. And at that time, there was a lot of activity on the Hill, and people were keenly interested in better defining aspects of the Medicaid buy-in, establishing a premium structure in statute. They wanted to speak more directly to income and eligibility standards for the buy-in and give it better definition. The theory was that this would incent states to come in and take advantage of it because it was better defined, and therefore states felt like they had certain controls perhaps over how the types of individuals and the earnings that they'd have coming into the program. Of course, there were partisan differences, good-hearted ones. Everyone shared the goal of helping people with disabilities get to work, but there were discussions about who's going to participate. Would individuals with higher incomes with large amount of assets be coming into the program to participate and taking advantage of the Medicaid program when they might be able to get their health insurance coverage elsewhere? So the list went on and the conversations went on, but it did pass. And we are left with these two eligibility groups in statute. So I'll just add that there was the state of Massachusetts, which was really leading the way, and they had been operating under the research and demonstration waiver, the 1115, I believe since 1988. So there was this history that the Congress could tap into to see how state could use this newfound flexibility in the program.
Thank you, Henry. Beth, could you tell us a little bit about your experience? Oh, Beth, you're on mute.
Sorry about that. I'm off mute now. You're right, Henry, that in 1988, Common Health first passed in Massachusetts, and it was originally part of Governor Dukakis's push for universal health reform, and really is the only thing that in the end actually ended up being implemented from that effort in Massachusetts to do universal coverage. And we started the program before the waiver, but our waiver started in 1997. And when I began at Medicaid and we were working on the waiver, what we allowed is for Common Health to cover both adults and children. And I know the focus today is just on working adults, but I think it's important to note that in Massachusetts, the Common Health program also covers children with disabilities to any income level. And that's true for adults as well, that there is no income limit in Massachusetts in terms of the ability to get on. So it's different from what you see in the federal statute. And we allowed for there to be no asset test as well as part of our waiver. But what we did do is have very high premiums as your income goes up. And that was to address the fear that Henry raised about people getting on the program and using Medicaid instead of using their income and assets, because the premiums were so high as your income went up. Some people could have upwards of $1,000 a month in premiums. You really needed to use a lot of services in order for Medicaid to be worthwhile as your premiums went up. And we also, as part of our program, required individuals to take their employer-sponsored insurance. That was something that Massachusetts focused on from the beginning, regardless of whether someone has a disability. But if employer-sponsored insurance is offered, to use that and to use Medicaid as wrap to that coverage. And so that also helps contain the costs. And so we have been running the program for over 20 years now, and it really is a lifeline for individuals with disabilities who want to be working.
You know, we've talked a little bit about the program itself, but could we talk about why it is important to individuals with disabilities? Henry, would you start us off?
Sure, I think it's a critical point, and thanks to Kathy for raising the example. I think someone living with a developmental disability or behavioral health issue may find some really unique services and supports that are only available really through the Medicaid program. And so while they may carry employer-sponsored coverage or some other form of healthcare coverage to cover the more traditional medical needs, the reality for people with disabilities is the Medicaid program is unique. It offers up services and supports that we can't find anywhere else. Another really solid example is the personal care benefit. And I think most people that have worked on long-term services and supports for a while understand that they just aren't available any other place. Paying private insurance companies to get coverage, you're automatically disqualified if you come in with a pre-existing need for these long-term services and supports. Thus, the Medicaid program really is the only place where people can get the ongoing kind of home and community-based services, personal care, to make sure that they're ready to go and get to work in certain cases. Hopefully, that helps give you some insight into the populations and their needs.
So you mentioned private insurance. Someone might have employer-sponsored insurance and still need the Medicaid program. And we understand that, you know, there are things that are not covered under traditional health insurance. Could you talk a little bit, or could someone talk a little bit about how the two types of insurance interact? Do you have double coverage and then extra coverage under Medicaid, or do we have, how exactly does that work?
I could just open quick, Kathy, and mention that it's not unique to this group. There are often children in families with extraordinary medical needs, and those families have employer-sponsored coverage or, again, some other form of health insurance. And the Medicaid program wraps around that benefit that's available to the individual and the family. That indeed can be the case here as well. So if an individual is participating in another health insurance or another healthcare program besides Medicaid, Medicaid simply wraps around that benefit. Remember, Medicaid is a payer of last resort. So I think we have that as some assurance that there isn't this rush to look to Medicaid to pay first. I'd also add that the provider networks are probably more expansive in employer-sponsored coverage or, say, in a Medicare program. But others may have something to add.
So, in effect, what you're saying is that the Medicaid program, as the payer of last resort, is the one that, so if I needed health insurance coverage, if I were hospitalized, then my private insurance, my employer-sponsored insurance, would pick up all of those costs. And typically, it is only the day-to-day personal care assistance services that were not covered by my private health insurance that Medicaid will pick up. So it really does lower the cost of health insurance to the Medicaid, or lower Medicaid costs for states. Beth, could you talk to us a little bit about that and what your experience has been?
Sure, and I just want to emphasize Henry's point that this is not unique to the Medicaid buy-in program for working adults with disabilities. This is true for the entire Medicaid program. There are requirements in the federal law that states look to employer-sponsored insurance through the health insurance premium program, and that they access that insurance when they can, for just that reason, because if someone has access to employer-sponsored insurance, then it reduces the overall cost to the Medicaid program. And personal care attendance is an easy example because that's not covered in an employer-sponsored program. But there's other services where you might have limited coverage in your employer-sponsored program, but Medicaid will pay for the rest. And so that's really where the payer of last resort comes in. Medicaid is always the second payer, and particularly because we know that most Medicaid programs use managed care. It's important for the Medicaid managed care companies to look for that third-party coverage first, to get payment from that first, and then to look to the Medicaid benefit to pay it the rest. And so that's usually taken up in their premium. And so for individuals with disabilities, I think generally, if people aren't familiar with the program, you often think first about individuals who have physical disabilities, and that's sort of where the PCA comes in. But we know in the Medicaid program that many of the individuals with disabilities actually have a developmental or a behavioral health disability. And for those things, in many instances, private insurance only pays so much or only covers so much of the service. And it's really essential for Medicaid to wrap around that service and provide additional supports to keep people engaged in the community.
Great, thank you very much. I'd also like to keep Michael and Seth engaged in this conversation as well. In doing some of our background, I was trying to rely a little heavily on Henry and Beth. So here is a question that is coming from one of our viewers, Ari. How has the population using Medicaid buy-in changed post-ACA? Are we seeing a big difference there? And maybe if no one's willing to jump in on that, why don't we ask Michael and Seth about how members of Congress perceive this program? Is there a lot of bipartisan support for it?
Kathy, it's Michael. I can jump in on and actually follow up on a point that that Henry and Beth made. Beth highlighted that often personal care attendance is a service that Medicaid buy-in provides with the wraparound in addition to private insurance. Durable medical equipment is another area that often is an area where it fills in for. But I want to go back to what Henry started saying about this program, and that's that so many individuals who rely on Medicaid, and particularly for those services and supports that are not covered traditionally or fully by private insurance, it's just almost immobilizing to think about losing Medicaid. So the structures that we have in place around asset limits, around earnings limits, really force many people to make a hard decision about staying in poverty in many cases, or to have control over their own economic well-being and their own economic health. So this program is so critical for people with disabilities. So that doesn't get to your specific issue about how, or Ari's specific question about how the populations have changed, but I just wanted to drive home how important this program can be because of essentially a cliff of not being able to get those additional wraparound supports and services.
Yeah, and this
you.
is Beth. I just to Ari's question, I don't know that the ACA has reduced the need for these services at all, because the coverage that you can get through the exchanges is maybe broader than some commercial insurance, but it's likely not to cover all of the services somebody with a disability would need. And so that while the ACA is helpful for individuals at higher income levels, for sure, it doesn't take away the need for this type of program for somebody with disabilities.
And Beth, to your point as well, I was going to say, sorry, that I know in the state of Ohio, for example, that our eligibility threshold for the Medicaid buy-in for people with disabilities, right, goes above the 138% federal poverty line for Medicaid expansion. So, for those folks, it's largely unchanged. And if you were qualifying beforehand, you're still going to be receiving your Medicaid coverage in that capacity. And so I think, it remains very important, right, for those folks to continue having that access. And I think that remains integral. And maybe to the initial question that was raised as well from Catherine about in terms of, where is the bipartisanship and where does Congress see some of these roles and relationships with this program? I think a lot of members, in particular Senator Portman, who I obviously can speak for here, really believes that, for people with disabilities, that Medicaid can be a real integral program to support independence, and obviously an array of independence through the variety of personal care services that we've discussed, and can give you that independence to seek work or substantial gainful activities, what have you, and feel like a participating member of your community.
And thinking about, go ahead.
Oh, Catherine, I was just going to, not to belabor Ari's question, but it does give an opportunity to draw an important distinction that individuals participating in a Medicaid buy-in for workers with disabilities actually meet the Social Security definition of disability, and therefore they are eligible for the program. And those individuals participating in the ACA expansion would have already been in the Medicaid program had they been able to meet that more stringent disability criteria. And therefore, it's really a distinct population. Those individuals may have disabilities, but they probably didn't rise to the level of the Social Security definition.
And before we get off Ari's question too, I think maybe one thing that he might be getting at, although I'm only guessing here, is that with the Affordable Care Act and the elimination of pre-existing condition exclusions, minimum benefit packages, and the the requirement to renew health insurance, regardless of your status or your health status. I would imagine that individuals, workers with disabilities, if their employer doesn't offer coverage, or even maybe through their employer coverage, they would be able to have a better benefit package and more secure private long-term care insurance package. And I imagine that might take some of the pressure off the states as well. So moving to our next question, there has been a lot of discussion, at least we have heard a lot over the last year, about the complexity of Medicaid buy-in programs. Could you talk a little bit about that? We know that states must combine perhaps provisions from different programs, maybe continue to use the 1115 waivers and other waivers to put these programs together?
I could jump in, but I think, Beth might have some additional expertise here that would be worth I would just start with, back to the basics. So the Balanced Budget Act creating a hard cap on earnings at 250% of poverty is fairly limiting. And so, although that may cover a large number of individuals that the state believes interested in work, one way to think about this is that it is one way to simplify some of the Social Security earnings disregards to maintain your eligibility, which is perhaps a little too technical for our discussion today. But it was an easier way to get a job, be paid, and maintain access or eligibility to your Medicaid program than going to the Social Security office each month and making sure you continue to qualify for the SSI program, which is how they're attached to Medicaid. So that was kind of a starting point for states. With that, the Ticket to Work added the layers of how you would structure the benefit. There were earning limits, but they went up, and they were attached to a premium structure. So states weren't required to cap earnings, but they were, operating attached to a premium structure. And so those were put in place by Congress as a way of protecting the individual from being charged too much for access to the Medicaid program when their earnings weren't high enough to sustain it, I imagine. But I don't know if this is really getting to the current challenge that states face and trying to do things like lift the income and the asset requirements of the program. And there, I think Beth has some experience that's highly relevant.
Yeah, thanks, Henry. So I think our experience in Massachusetts was different because we started before the rules were put in place, and I'd say that between the Balanced Budget Act and the Ticket to Work, as well as the waiver flexibility, there is the ability for states to put together a program that works, that doesn't have to be confusing for the individual. So Medicaid programs are confusing just by their nature. There's a lot of work that the state has to do behind the scenes to administer it, and they want to make it the least burdensome for the state as possible. That's particularly important when you have a program like this one for individuals with disabilities, because it's going to be a smaller portion of your population. And so thinking about how a state has the resources to devote staff time to these programs is important, whether it's for a small program like this, if it's for individuals with HIV, for example. There's the same amount of work regardless of the number in the population. So that's something for states to think about as they're putting these programs together. But once you put the authorities together to do the program you want to do, it's really thinking about the administrative burden from the perspective of the individual member and how hard it is for that beneficiary to remain engaged in the program. And so that's thinking about what that means in terms of the eligibility and asset requirements. If you want this to be a sustainable model to allow individuals to meaningfully engage in the workforce, you want to have higher or no income limits or no asset limits to allow people to grow in their jobs and their careers without having to worry about losing Medicaid. So that's one piece. And within the Medicaid program, you all know you have to continuously apply on an annual basis or renew on an annual basis for your income. So just having to do that is a burden of itself that sort of can keep some people off the program. The other piece is that you have to continuously show that you have a disability. And so even though you're eligible through SSI, there are some requirements around renewing that or showing on a regular basis that you continue to be eligible. And that also can be hard for someone to keep up. And so something to think about over time. And then the final thing is about paying the premium. If you don't pay your premium every month, then you can lose your eligibility. And so that's a third piece of the burden, and particularly during COVID, where many workers have seen a loss of income. That's a big deal for individuals to try to grapple with as they do this. So there's administrative burden to the state, and then there's administrative burden to the member. And I think it's important to think about both things as you're putting programs together.
So when we think about, oh, Seth, your mic is off.
Is it on? I'm sorry. Okay, great. Sorry about that. I was saying I just wanted to hopefully speak to the points that Beth said, just in that I think, when we talk about, I think Henry and Beth both presented two good options in terms of how do you expand eligibility and access to the program. But I think Beth in particular, you really talked to the point around, are there folks already eligible for the program that are not taking advantage of the program? And I think that remains key for a lot of folks in Congress right now, in making sure that the program as is working to the fullest of its potential, potentially before you even go further and adding more to it, who may not already necessarily be eligible. So, thinking about in terms of what can we do to reduce the burdens on the beneficiary side, and what can we do to reduce the burdens on the administrative side, whether that's the CMS level or the state level. I think that's key. And I think that's where you would see a lot of bipartisanship in Congress in terms of how you figure out how to make that process, the existing process that should be work better, because as we know, it certainly isn't. And there are folks maybe who are slipping between the cracks where the burdens are too high for them to really overcome and meet the requirements for the program. And I think that is where you can see a lot of hopeful action there. And, obviously some can be done by Congress, and hopefully some can be done by the administration. And sometimes you hope that the administration can move on those things, because it's a little bit easier for them to do things than for, all 435 members to agree on.
Michael?
He agrees.
Would you like to jump?
Didn't hear.
Would you like to jump in here? As I was talking about what's going on in Congress. Do you have anything to add there? And in fact, we could jump ahead a little bit. We as the entity in the coming Congress.
Let me provide maybe just a general framework from my boss's point of view. And then we can get to some specifics in terms of what might be coming forward with Congress. The Medicaid buy-in program, Senator Casey really sees as a component of how do we break down some walls toward moving people with disabilities out of what's essentially a stuck point in terms of their ability to earn a decent wage, and be able to be, as the ADA says, economically self-sufficient. The fear of losing either primary health care or the essential wraparound support health care that Medicaid provides, as I said earlier, is a real barrier to many people with disabilities. But so are other things. Things like, and the report does this very nicely, it lays out what the intersection is between supplemental security income and Social Security disability insurance, the asset limits that are involved in those programs of $2,000 plus some exemptions such as one car and a dwelling and some other things are often a problem. The report also points out the challenge that substantial gainful activity, essentially monthly earnings, are in terms of being able to move forward. And the center really sees these as all interconnected, that we have to address the barriers that these pieces put in place to people being able to get jobs, being able to be promoted in their careers, frankly, being able to move from state to state because there are limitations there as well, either for education purposes or to take a better job. All of these things limit people with disabilities, and we need to address them all, including a robust MBI program. I would be remiss if I didn't point out that Senator Casey, back in 2014, with a really strong bipartisan group, moved the ABLE, Achieving a Better Life Experience Act, which, if you open an account, you can actually have more savings in that account so that you can expand the number of assets that you can have in hand for things like disability expenses. And that includes education and moves and alterations to an apartment or a home, many, many, many things that those dollars can be spent on. And the federal limit there is $100,000 instead of the $2,000 that we find with many of the federal programs. And I really like the fact that this report doesn't only focus on the Medicaid buy-in program, but it puts it in the context of these other pieces, so that we can think about how do we actually help people be economically self-sufficient and economically healthy moving forward. And I'll stop there. And we can talk more about what's actually taking place in Congress and what some of the plans are, certainly, to address some of these barriers.
Catherine, if I could add to some of what Michael points there, one thing I think that needs to be clearly stated and understood is that many beneficiaries, many people with disabilities that rely on Social Security income still really don't understand that there are options in the law for them to go to work, have earnings, and still maintain access to their benefits. So there's a really significant kind of outreach and education component that the report speaks to, but that hopefully, as the Hill looks towards the future, the members will bear in mind the importance of educating people about these options. I would extend that to also people working in state government and sometimes even in the Social Security Administration. There's a lot of complexity here, and oftentimes staff members are moving from one part of the operation in Medicaid to another, and they're really unfamiliar with the eligibility standards and criteria for a program like a Medicaid buy-in, because it is fairly unique. So the education and outreach certainly should be targeted to beneficiaries, but there's much we can do with states to really provide technical assistance and raise their level of awareness of how they can work with the existing authorities like Beth was mentioning.
Great. For those of you who are just joining us, I'd like to remind you to submit questions in the live chat on YouTube or Facebook, or through Twitter using hashtag BPC Live. So let's talk a little bit about the differences between state programs. We have heard that some states have, been very aggressive in reaching out or taken advantage of the many waiver opportunities. How does this make the programs look different from state to state? How do they vary from state to state?
So I can start, and maybe Henry, you can jump in. think that just like with the Medicaid program itself, if you've seen one Medicaid program, you've seen one Medicaid program, and that is the same thing for a Medicaid buy-in program. Because there is so much flexibility for states in terms of how they put their programs together. You can't look at what Massachusetts has done and say anything about what that means for New York or Colorado or one of the other 44 or so states that actually have a buy-in program. They really are very state specific. They all have something in common though. They all have an eligibility income review, whether or not that's used to limit eligibility or to set premiums, depends on the state. They all have services that is provided, that might be provided just for this population, or it might be provided for a greater piece of the population. So for example, in Massachusetts, personal care attendants are part of the comprehensive benefit package that anyone can get as long as they need them. In some states, these personal care attendant services might only be available for people who are in the buy-in program or some other pieces of the program. So really you have to look individually at each state to see how they have implemented it, to see what it is. And so from a national perspective, it is really hard to look at it, but I don't think that's different than how the rest of the Medicaid program works. Really, because we've allowed states flexibilities, we do see different programs, and depending on which avenue a state has taken, a state might just use the BBA option because it's easy. You can do a state plan amendment, and you can take a step towards supporting people with disabilities go to work without sort of creating too much burden on the state side. And so some states might decide to do it that way, and other states like Massachusetts sort of have gone all out and put together a program that tries to be as comprehensive as possible. So really, they run the gamut. And part of it is also going to be about what the state's budget is and how much they feel like they can devote to it. Because if you just have a pretty low income level, like that 250% of the federal poverty level, you can make an estimate about how many individuals you're going to get in. And I will say I'm not up on the Massachusetts numbers to date, even though Massachusetts had no income limit. Most of the individuals who are on the program in Massachusetts really did fall within the lower income levels. It was very rare to see people whose incomes were at 800, 900, 1,000% of the federal poverty level. They were really much lower, but perhaps higher than that 250%.
Yeah, and to be clear, for those of you who are not familiar with the federal poverty limits, and someone jump in here and correct me because I haven't looked at it recently, but it's about $16,000 a year for an individual. So when we talk about 250% of poverty, we're not talking about, very high incomes here. I know that states, and both you, Beth, and Henry have alluded to this in some of your responses, but when this program was first implemented, 20 years ago, there was a real concern both on the part of members of Congress and on the part of states that if you started opening up these programs to higher income individuals and allowed them to retain more assets and still qualify for these programs, that there would be a significant impact on the federal budget. And Beth, you mentioned Massachusetts, but can anyone, maybe Henry or maybe Michael, talk about what actually happened and I think the records we've seen or the numbers that we've seen lately show that about over the last decade, around 400,000 people nationwide have taken advantage of these programs. Could someone talk about that a little bit?
I can jump in on that, Catherine. Unfortunately, the Medicaid buy-in that was created in 1999 came along with a kind of package deal, the legislation. And in there was a pretty thorough evaluation of the program and many of the aspects of the law overall. And so at that time, when they did their study of the Medicaid buy-in, there weren't significant findings that states were bringing in higher income individuals and that people were, that the Medicaid program was absorbing a cost that should have been elsewhere. The program hasn't been looked at with great rigor, I don't think, since then, but the numbers really haven't changed. The level of participation in the state is relatively stable. Back to an earlier point that Beth was making, a state could, if your advocacy community is going to the Medicaid director and saying, we want to work and we want a Medicaid buy-in, well, you could just turn to the BBA option, as she said, submit a state plan amendment, and now you're able to offer people the ability to earn up to 250% of poverty. That may satisfy a large or significant number of individuals interested in working and participating in this program, but it really does shut out some of the individuals that might be able to earn above that limit and have, economic mobility where they could, again, acquire either employer-sponsored coverage or, gain access to health care elsewhere, and then just have the wraparound that we've discussed about Medicaid. And so Medicaid actually doesn't realize some of the savings that it could when individuals earn more and thus become eligible for a more expansive provider network through employer-sponsored coverage or something now that might be available through the federal exchange or the state exchange. So I hope that got to your point.
Yes. Anyone else want to weigh in on that? I have a few more viewer questions here. Robert asks, how can people with disabilities be educated on these options? There seems to be no one single entity at the state or county level to delineate what these options are. What sort of policy changes could be made either at the state, federal, or local level to improve that understanding?
Well, I jump in and put an advertisement again for the benefits counseling and the outreach that was supported in the Ticket to Work and Work Incentive Improvements Act. I think that, along with the Medicaid infrastructure grants, really stimulated a significant conversation in states about employment, how to go about achieving it, what you would need to do at a state to put the pieces in place to support people to achieve higher earnings. So I think, at a minimum, you would want to reinvigorate some of those efforts. One of the challenges is the Medicaid buy-in lives at CMS. The bulk of the work incentives really reside over at the Social Security Administration. So in the Ticket to Work Act and its implementation, there was a great deal of coordination between those two, the department and the independent agency of Social Security. That collaboration has really fallen off. And I think, we need to look very carefully at how to ensure that CMS really has the requisite expertise on board to provide the right technical assistance to states so that they understand what their options are, and that the Social Security Administration was a strong partner in making sure that their joint beneficiaries really understood how to use various work incentives, including the Medicaid buy-in. And to put a punctuation mark on this, I would say that there is one resource that the Social Security Administration produces. It's called the Red Book. And if you just simply put that into your web browser, you can go out and get a copy of it. And it's a lengthy list of how to do your income disregards to maintain your Social Security eligibility. And it has a couple of plugs for the Medicaid buy-in and a program like 1619, which allows people to maintain access to Medicaid when their earnings are there. So again, that's the Red Book, and it's a product of the Social Security Administration.
And I think at the state level, there's also opportunities for there to be better coordination across Medicaid and other agencies. that might have more of a day-to-day focus on individuals with disabilities, whether it be the mental health agency, a developmental disability agency, a workforce development agency, a rehab commission. There's a number of agencies that are closer to the population that Medicaid agencies can work with to get the word out about buy-in. I think, the Medicaid program is hard and complex, and to focus on a relatively small population does take the need for leadership at both at the Medicaid agency level as well as the other state agencies to really take it on as an issue and decide to prioritize it, because there is a lot happening. And so if you think about what Medicaid programs have been trying to do over the last several years in terms of implementing the ACA, moving towards value-based payment, all of those, better integration for duals, really, it's hard to do those big projects and other things. And so you really do need to find a champion for the program in order to sort of make it a priority at the state level. And that might be why you haven't seen a lot of activity over the last several years.
Mm-hmm. We mentioned before that this program, or go ahead.
Catherine, I just want to piggyback on what Beth and Henry said. I agree with Henry 100% that the benefits counseling was extraordinarily useful in rolling out the idea of Medicaid buy-in. One of the things that we've found with the ABLE accounts is that, as Beth said, is to try to reach people where they typically have contact with other programs. So if it's SNAP, if it's the Social Security Administration, if it's the IRS, if it's possibly HUD, all of those places are good places to forward this information and get people to be knowledgeable about MBI. The trouble is that those individuals, those workers who are often extraordinarily good, but also burdened with so much information, need some really good information for them. So around ABLE, we worked closely with HUD to be able to get some training and get some information to the grassroots online workers to be able to share information about that. So there needs to be a really concerted effort where possible beneficiaries of Medicaid buy-in would have other contacts with governmental offices. And Beth alluded to that as well. And I'm thinking that at the federal level, at the many programs where they might interface with federal programs, we need to get that information to those workers as well.
Great, thank you. So we have another viewer question. Zully asked, could you also address people with disabilities who are self-employed and do not have insurance unless they qualify for Medicare? Not everyone can be employed in traditional forms.
Well, I can talk about it from the perspective of the Medicaid buy-in program. It does not require that there be other insurance. So we didn't mean to imply that that was the case. You're right that there's many individuals who are working and disabled who are self-employed, and I think that will only increase over the years in terms of the kind of gig economy we have now. And so if that is the case, you will, it does create some issues in terms of really showing that you have income from work, and being able to do that from a state perspective in terms of ensuring that there's not fraud in the program. But if you are eligible and you are working, and it's for yourself, and you don't have any other insurance, there's not a requirement for you to buy it. Then Medicaid pays for the full cost. It's not a wraparound. You get all of the services within the Medicaid program.
I might also mention that, and maybe it would be helpful if someone could talk a little bit about the differences in how you qualify for Medicare versus how you qualify for Medicaid and how those two programs interact. Henry, I hate to put you on the spot, but could you help us out with that one?
Well, sure. Just the simple, straightforward answer. So someone qualifies typically for Medicare when they're under age 65 because they acquire a disability. So they participate in the Social Security Disability Insurance Program. They wait 29 months after they've been determined eligible, and then they begin to receive Medicare. So in that 29-month run-up, they may be eligible, or they're likely eligible for Medicaid, depending on the state and their income. And then, Medicare kicks in and they become a dually eligible individual. And so there's an interaction there. For SSI, the program, if you become eligible for SSI, Medicaid is attached to that program, and so the states then offer that up to you as your health insurance. And so those are the two traditional pathways. Most, it's hard to generalize. Many of the disability advocacy community, I think, come at this from an SSI standpoint. There are a large number of individuals that participate that have Social Security disability insurance. Just to get an insight into that program, about 70% of them are over age 50. And so many times people acquire this disability at an older age and they may not be able to return to work. That's a huge generalization. I wouldn't hold it out as true for everyone, but there may be lower rates of reemployment there in that population. But there are certainly people in that other 30% of the DI participants that may have acquired it at a very early age, and they are eager to get back to work. And the lack of Medicaid that comes, or the lack of services that Medicaid makes available are, again, uniquely available in the Medicaid program. So they're really looking to Medicaid to wrap around that Medicare benefit. So the example there would be somebody whose Social Security disability insurance monthly payment is higher than the state's typical Medicaid eligibility level. And therefore, a state offering a Medicaid buy-in for working disabled people would allow that individual, if they went to work and had earnings, to come in and hopefully pick up the Medicaid program, again, depending on if that state has income limits and how it's structured. But that doesn't do it justice. There's another eligibility pathway for disabled adult children that is relevant, but I think for purposes of today, that might be enough.
Michael, I saw lots of nodding going on. Is there anything you'd like to add?
No, I think Henry did a good job of reviewing that. Thank you.
Okay. One last point I'd like to make on Zully's question is that for those who don't have employer-sponsored health insurance or who do not qualify for Medicare, there is now, under the Affordable Care Act, insurance marketplaces through which one could purchase private health insurance coverage, and depending on your income, at a subsidy, with a subsidy to help bring down those costs. So one of our, before I go to this next question, we have another viewer question. Claire asks, what do you see as the main challenges to expanding Medicaid buy-in programs in this Congress with this administration? Is it cost? Is it complexity? And I will add, is it COVID-19 as a priority? Could you speak to that a little bit?
So Catherine,
Michael,
I'll jump in real
Michael,
quickly. I would say it's probably all of those, frankly. We have a lot of competing needs. You've seen since March how many packages that have been put forward, and whether it's schools or it is direct service workers or whomever. The challenge is that there are just so many needs with the pandemic right now. I think the recommendations that the report offers are really, really good steps, and I think the administration, once there's some leadership at CMS, and I would also nod to the administration on community living, can move forward with some of these recommendations. But it is just a ton of noise right now in Congress, and as you've seen, the new administration is really focusing on what they're calling a rescue package, and then more than likely there will be an economic recovery package as well. So those are going to take so much of the priority in the coming year.
Seth, would you like to jump in?
Yeah, happy to. Is my camera working again? Sorry, it froze there for a second. But yeah, I think Michael's point about oxygen in the room is, I think, really key at this juncture. I think that, getting the members to focus on a wide variety of issues has always been a challenge. And I think especially during the ongoing pandemic, it has been especially challenging to focus on a lot of things that are anything but COVID related at the moment, which is why, I made a little bit of a veiled reference earlier to that, sometimes administrative efforts can be a little bit easier since they can be more unilateral in terms of getting things done. Obviously everyone wants to be active and be bipartisan, but sometimes, if there are barriers that can be taken down on an administrative or state level, that's certainly a preferred route sometimes for folks, especially if they're common sense and bipartisan. But I actually want to highlight maybe one of the recommendations from the report actually that I thought was really good, which is renaming and reterming the program to, paraphrasing what you guys called it, but the program associated with Medicaid for people with disabilities. And I think that is key in reframing the context of what the program is and what it can be, and maybe taking out some of the stigma that may be associated with partisan terms associated with buy-in, for example. And I think that if you can make it something more common ground for folks, that could be really key in addressing, maybe commonalities that folks share on the issue.
And Catherine, I would build on Seth's point, just in the health policy community, there's discussion about how Medicaid buy-in, how a state could use Medicaid. I think, it touches on the partisan issues that Seth began to raise there, that, for people with higher incomes, Medicaid could offer services. And taking it away from being a low income program is, definitely something for debate. But the reality is that this program has in some way been eclipsed by that discussion. And therefore, nowadays, if you say Medicaid buy-in, more often than not, you're going to, the audience is going to respond with, what are you trying to do to the Medicaid program? Are you trying to raise income limits for people that, could be eligible for health insurance elsewhere? And so putting the emphasis back on the workers with disabilities, I think, is really critical for getting the right focus on this program, and frankly, why there's a need. I mean, we need these eligibility groups just for this purpose. They can't access the program other ways.
Thank you. One of our other recommendations was suggesting that CMS issue regulations for these two programs First, why do you think the agency has not done that in the last 20 years? And what would be the benefit of going through the regulatory process, the notice of proposed rulemaking?
Well, I could open up and hopefully Beth can jump in. I think really codifying the approach is more than symbolic. It helps give some definition and guide states. But I would argue that, what comes with that might be the technical assistance effort, the raising of the profile, having conversations with states, talking about how it can be used, going through the public process of having something available for notice and comment really brings out those parties that are most interested and knowledgeable in the program and allows them to contribute to better defining how the program might be structured and used going forward. And so I would also suggest to the incoming CMS administrator that they make sure that they have personnel in the eligibility shop that are really dedicated to overseeing this program so that it really gets the attention that it would need before you go through a process like rulemaking.
Yeah, and I'd add, short of rulemaking, the other thing you could do, I don't know if everyone else saw, but the previous administration recently released a guidance letter on social determinants of health. It didn't say anything new, but it actually was pretty effective, I thought, on sort of bringing to the forefront what you could do with current flexibilities around social determinants of health. And the Biden administration could certainly do that for the buy-in program without having going through the full regulatory process, so it wouldn't get you all of the attention that you would otherwise get, but it might be something that could be done quicker and still have the same effect of really getting out there with the program and reminding people that it's there and can be used. As a state official, I might be a little bit wary of regulations, to be honest, because the different states have been running these programs without regulations for a number of years. And so anything that you put into regulations might require states to change how they're doing their processes today. And so if that was going to happen, it would be something that you would want to be done carefully. But I do think that the idea of CMS coming out with some sort of state health official letter that describes what you could do with the buy-in program could be very, very beneficial.
Okay. So I have pretty much exhausted the questions that I've put together, and we have not gotten any more viewer questions. Oh, wait a minute, one coming in. I knew if I started, we would get one. Christine asked, does the report recommend eligibility for higher earnings levels? The way Massachusetts does it with higher premiums seems sensible. And I can tell you that our report does not do that. We don't make specific recommendations with respect to eligibility, but our understanding of the program, at least when we put it together based on the advice that we got, that flexibility currently exists, and that it was more important for us to point out that flexibility and to get that guidance out there. Does anyone else want to weigh in?
Yeah, I'll say, Catherine, the report does comment on a policy proposal that Senator Portman and Senator Casey have actually been trying to push for over the years, which, maybe that's why we're here, maybe not. But, in terms of lifting the age of eligibility for the buy-in program above the age of 65, obviously the full age of retirement now is 67. And I think in general, our respective bosses felt, when they introduced a bill last Congress and hopefully are working to reintroduce it this Congress, that age shouldn't necessarily be a prohibition on your ability to work. And if you have the means to work and and you want that, then it certainly should be an option for you. And we want to, find a way to lift that age restriction. And the report touches on that too. And I think that's, at least one way to extend eligibility further. It's not necessarily adding new categories of eligibility, but it's ensuring that those who are already eligible can continue to be eligible.
And Catherine, to put a couple of points together here, to Seth's point about what the senators have been pursuing about extending eligibility over age 65, along with Beth's very good point that sub-regulatory guidance is also a good way of helping states understand. CMS could write, this sub-regulatory guidance and issue it that would clarify how states could structure their Medicaid buy-in program so that someone's eligibility doesn't have to terminate at age 65. So there are maybe members of the Hill will write to the agency or something like that, who knows. But there are ways that it could be done. And I think back to your point about bandwidth and where is it going to come from, given that we're living with a public health emergency and likely to be in some form of economic recession afterwards. Where does this energy come from? And I think the reality of putting people to work might be a wind at the back of this issue that people could bear in mind as they talk to people about the importance of this program, and that people with disabilities want to participate in an economic recovery as well, and that making these changes or making it clear to states how to structure their Medicaid buy-in program so that more people could participate might be something that would be consistent with how an administration lines up its activities at some point in the future.
Yeah, and just to piggyback on that, I'd say lots of people at the federal and state level are really focused on health equity right now, and equity overall, and have been consistently moving beyond race, ethnicity, and language to include disability within that structure. And so with that sort of frame to it, it might also be a good time to reintroduce the buy-in program.
Thank you. We have another question. Hannity asks, how might expanding programs like Medicaid impact us economically, especially in terms of the federal deficit?
Well, I mean, I can take that from the state perspective. I think depending on what state you're in, the federal government is reimbursing somewhere between on a regular basis between 50 and say 75% of the program. Now it's a little bit higher with the public health emergency and the enhanced match that states get. But I think it's important to note that anytime a state enhances their program, they're also putting money on the table. And so from the state perspective, they're not going to put money on the table unless it's something that they feel like it's worthwhile. And that's true whether you're a state that's 50% or a state that's at 80% match, because that dollar you have to put on the table is still a limited resource.
And just to add on, the fact that individuals are earning money, they are paying taxes, and so that's revenue back to the federal government that otherwise they wouldn't receive if these individuals weren't participating, in the labor force. So there are benefits and costs, but again, I think the evaluation of how the program has worked showed that there wasn't a huge impact on federal spending here, but it would be great to expand Medicaid for this population. I think it's proven to be quite narrow. We know that the employment rate of people with disability is quite low. And since we have the time, I'd mention that I know a number of people in the advocacy community are pursuing more opportunities for people to participate in competitive integrated employment. And that would imply earnings. They would be earning, say, above subminimum or above minimum wage. And with that, they would be having to deal with these eligibility issues if they rely on Medicaid for support. So I think there's a real need to think about how these work incentives, particularly the Medicaid buy-in, works in conjunction with efforts to expand competitive integrated employment for people with significant disabilities, which there's lots of talk about, getting rid of subminimum wage for people with disabilities. And if that were to happen and people were to be paid more, they would have to pay close attention to how it affects their Medicaid eligibility. So again, be more expansive and comprehensive in your thinking about the individuals that we're advocating for here, and making sure that there aren't unintended consequences to our efforts to ensure that people have, a meaningful life by participating in real employment.
And Catherine,
one comment. Go, Michael.
Sorry, Seth. You want to go first?
No, you can go. It's okay.
I think the other side of the equation that Henry's talking about is the business side, and the report does a nice job of highlighting this, that if you look at a place like Home Depot or Walgreens or any number of other employers, what you see is a higher level of loyalty, time in a position for people with disabilities who are hired in. You see a lower rate of use of things like sick time. You really see a higher productivity rate often as well. So the benefits to the employer and the business are significant. And when we calculate the cost of a program, we often don't calculate in those benefits. We tear our hair out sometimes in Congress as staff when the Congressional Budget Office only calculates the expenses that are going out the door and not the benefits that end up actually bolstering the economy. So people with disabilities actually contribute enormously, as Henry said, not just to the tax base, but also to the efficacy and the efficiency of the businesses in which they work.
Yeah, well, Michael's point is actually what I was going to comment on a little bit and say, there is an incredible value to bringing these folks into the workforce. And I think we always want to highlight that. The asterisk I was going to mention on a comment Henry said about the tax base is, from preliminary conversations, right, that we've had with the Congressional Budget Office, they tend to see, at least from their accounting methods, that the cost outlays that go out from Medicaid by, extending and expanding this population do outstrip the amount coming in from tax revenue. And that's okay. And I think that conversation is worthwhile having because we want to support these beneficiaries and allowing them to continue to work. And obviously the caveat, right, is I'm talking about only extending that population above 65. And, there could be different dynamics at play for younger individuals. But to the point Beth was saying, as core, it really comes down to, the pros and cons that the states have to weigh and that in terms of implementing their programs. And right, the states will pursue something if they think that it is a worthwhile investment for them and for their beneficiaries, their constituents. And they're usually pretty good judges of that, but it's obviously gotten that much harder over the past 12 months as the pandemic and the economic recession have raged on. We see not just in Ohio, obviously, but I can say as an example, but across the state, across the country, that Medicaid budgets are usually the first to get cut in terms of economic downturns. They are the largest percentage of a state's budget. If it's not education, it's Medicaid. And, when you start looking at where do you start cutting, it comes from provider reimbursements and starts limiting access to care. You start cutting per member per month for Medicaid MCOs. And, it can be a limiting factor on expanding access to services that maybe states see as peripheral or see as optional. And so, there's a lot there. And, I think our conversation right now are certainly happening in hopefully, taking place in a world without a pandemic and where maybe states are more economically stable. But the backdrop of right now, I think, is certainly still important in considering. And, there's a lot that we should maybe consider in the future too, in terms of how do we ensure that these populations can be supported even amidst a pandemic where state budgets are on the line.
Thank you. We have one last question from our viewers and then we'll wrap up. Harrison asks, are there specific states that are doing Medicaid buy-in very well, and what lessons can we learn from those states?
Well, I've talked a lot about what Massachusetts has done, and I think it's a unique program and how broad it goes. I can't really speak to how programs are run in other states, but I do think, just to reiterate one of the things I said before, in order to sort of keep the program strong, it's important that you have continued buy-in from the leadership of the programs in order to keep the appropriate resources on it. And I think, that's true across the Medicaid program as a whole for any of the programs, but particularly for this one. And I think the second piece I'd say is the ongoing education of the community and really making sure that you have champions within the community to sort of keep pushing the program forward and keeping it top of mind. Those are the two things for me from Massachusetts.
And just to call out a couple of states, I've heard people that rely on the programs in Colorado and Washington as two really good examples of how the state has invested time and energy in making improvements to those programs. People that I've had conversations with have reported moving from one, this 1619 program, which allows you to maintain access to Medicaid, over to the Medicaid buy-in in Colorado, for example. So that would, that change in behavior, I think, is an indicator of the success of its design. One thing that might be, just to put it out there, it's important to have people in the Medicaid operation that have good conversations with the governor's budget office, because they're often the first group to make decisions about what is going to happen to Medicaid. And so there are implications for the budget potentially, especially if it's not well understood what the state is trying to do with its design. And so just thinking about where to find champions in a state for this type of activity, it's important to remember that talking to the Medicaid program is good, but it's also good to build support in other areas of the state, other parts of the state government, so that there can be these more comprehensive conversations so that policymakers have a holistic understanding of what they're trying to do with the budget and why they want to extend eligibility to this group above a level of poverty that the program has historically operated with.
Thank you very much. And before we close out, I'd like to just take a minute to thank Michael and Seth and Senators Casey and Portman for their efforts in this area. First of all, in a very difficult time, to be working on anything on a bipartisan basis is risky. So we really do appreciate your doing that. And as a former staffer, I know how much time, as important as the senators are, how important it is to have the staff there who are willing to commit to a population, commit to a program, and staff their bosses really well. And then also, I'd like to say that we recently heard that Senator Portman is going to be retiring from the Senate. And I'd like to say, too, that he is going to be really missed as someone who will reach across the aisle and work with his colleagues on these issues. So I'm sure all our viewers will join me in thanking our panelists. This has been, it has exceeded my wildest expectations. And thank you very much. And best of luck to all of you. Take care.